Good evening, class. This is Professor Streb, and I'm coming to you with a voiceover for our Unit 9, Caring for the Patient with Common Perfusion Problems. I'm doing this to help you get prepared for your exam and just to give you something to listen to in conjunction with the recaps and reviews that come out to accompany this. All right, so when we're looking at what's important for you, you always start with the syllabus. The syllabus talks about all the things that are listed here. We are going to pull test questions from this material based on your syllabus. Dysrhythmias, heart failure, the CAD, everything you can see listed here. Hypertension, BUERGER'S, RAYNAUD'S, even up to amputations. These are all things that you're going to be responsible for. So I'm going to go over each of these slides and just highlight some of the important things from nursing perspective, right? Never forget, this is nursing school. You definitely need to learn things like pathophysiology. You need to understand the etiology of disease. All of that is important in your journey to becoming a registered nurse. However, our exams, just like ATI and NCLEX, are going to focus heavily on what the nurse's role is. What do you need to assess for? What kind of data would make you suspect there's an issue? What interventions can the nurse do? What would you anticipate the doctor to order? Certain medications, things like that. If a doctor orders a medication, you need to know what the medication's for, how it works, what you need to teach the patient when they take that medication, especially when you're thinking about safety, falls, things of that nature. So while I want you to learn everything in the book is a fantastic resource. It is just that, it is a resource, and you can't memorize everything in the book. It's virtually impossible. So these are some things and some tips that are going to help you kind of just better understand what we're looking for. Cardiovascular assessment is right at the top of what you need to do. Just like we do in lab, we're going to have you out there assessing cardiovascular. You're going to look at pulses and things of that nature. You also have to listen for heart sounds. Make sure you remember, just like it says on here, when you're looking for the apetum an or aortic, pulmonic, Erb's point, the tricuspid valve, and the mitral valve, know where they're located. Know where you would hear different heart sounds. You have to understand which valve is where in order to relay to the provider what you're hearing. It's just not enough to say, I heard something in the chest. But where? What location? Did you hear something over the mitral valve? Did you hear something over the tricuspid? That's going to help you better identify for the doctor and then the patient's own well-being where a murmur might have been heard or something of that nature. So be sure you're able to identify based on anatomical landmarks where you hear certain heart sounds. Cardiovascular assessment happens nonstop. You constantly look at the patient. You're looking for their ability to walk and talk and perfuse correctly. They're not short of breath when they do things of that nature. Anything that lets us know that they're getting a good circulatory output and that they're perfusing all of the body parts. So that is something you're going to have to be very familiar with. Assessment also includes things like labs. You need to understand what labs are available and what each lab means. Understand that troponins are something we look at when somebody has a heart attack. That's something that we think about. The CKMB levels, that is also some of the enzymes that we'll look at when somebody has chest pain. Know what type of medications you're trying to expect the provider to prescribe. And then what kind of medications, what kind of labs you would have to look into, right? Think about all of these things. If you're on certain types of medications like ACE inhibitors, you're going to have to do these serum creatinine levels to make sure that your patient has good kidney function. Things like this are going to be important for you to remember. So yes, cardiovascular assessment entails a lot of things. It entails taking all the blood pressures and feeling for pulses. We're not going to really hit you on that because we expect you already know that. We want to make sure that you understand how to keep your patient safe, how to understand that if a patient's blood pressure is super low, we're probably not going to give them, their beta blocker or their ACE inhibitor. It's just you have to kind of pay attention. So look in the body of the questions and kind of see what's going on with the patient, and then think: is this safe? Is this intervention something that's going to make my patient better or worse? Dysrhythmias is a big one. I did an entire lecture that I posted on dysrhythmias, so if you want to go learn how to read EKGs, I highly suggest you go back and look at that again. It's definitely something that's going to be tested, not just here, but when you get to 265 and as you get into your 280 and your kind of comprehensive finals, these things are going to show up again. So it's going to behoove you to go back and really look at dysrhythmias. In order to know what's abnormal, you first need to know what's normal. Make sure you go back and look what a normal EKG looks like. What is normal sinus rhythm? How long is your PR interval? You know, we talk about that in the lecture I gave, the 0.12 to 0.20 seconds. A QRS duration, is it narrow or wide, right? Is it 0.08 seconds? The P wave. The P wave happens, and the P wave it comes before every QRS complex. P wave is your SA node firing, QRS complex is your ventricle depolarizing. And then a T wave, we know that a T wave comes after that ST segment. So you need to be able to identify what a normal sinus rhythm looks like. That's going to give you the basis to build upon, and then be able to recognize things like ventricular fibrillation, or pulseless VTAC, or somebody who has atrial fibrillation or a flutter. We're not going to get real crazy in depth on these, but we want you to be able to understand, what they are and what the priority treatment is. VFib, we're going to defib. You see VFib, you defib. Always. It's what we do. And then we kind of follow up with different kind of antidysrhythmic medications. Same with ventricular tachycardia. If it's pulseless, you treat it just like ventricular fibrillation. AFib, there's not a lot we do for AFib in an emergency situation, but we do give certain medications like ditalazine. That's something you can give. We think about a flutter. What we're trying to do is just make sure that we get a better cardiac output, and that we don't have a lot of just quivering of the atrium itself. So kind of go back and think about what some of the treatments are for these dysrhythmias, and that'll help you better navigate the exams and really understand how to successfully get through this course. Heart failure is a big concept for most people, but heart failure is heart failure is heart failure. Heart failure simply means the heart's failing to do its job, which is pump enough blood to the organs to perfuse them. So it's going to be important for you to understand signs and symptoms of heart failure, of course. We get that. So heart failure, left-sided versus right-sided. Left-sided heart failure typically involves some of the respiratory component, because the left side of the heart backs up into the pulmonary system. So you would expect, crackles in the lungs. You would expect, coughing or that wet sound, because they have fluid in the alveolar spaces caused by the pressure in the pulmonary vascular system. Weak peripheral pulses. The patients, if they're not perfusing their brain correctly because their lungs are full of fluid, think about that. Your patient's going to be restless. There'll be confusion. They'll have altered mental status. They could have pallor. They're not perfusing correctly, so they're going to look like they are a little pale. Things like pulmonary edema could arise because you got that backup of fluid. And if that's the case, you have to understand what the signs and symptoms of pulmonary edema look like. So when we're looking at heart failure, know some of the signs that lead you to believe that there's heart failure. But more importantly, after you recognize that, what are you going to teach your patient? So patient instructions are going to be very important. Make sure they weigh daily. Make sure they understand that if you gain, a couple pounds in a day, that's problematic. Or, 5 to 7 pounds in a week, that is also problematic. Make sure they talk to their provider about the inability to walk and talk at the same time. We talk about exertional dyspnea. If you can't do the basics like walk and talk or eat and talk, that probably is reminiscent of something going on with heart failure, because you're not perfusing your body like you should. So understand, things you want to talk to your patient about. Hey, if you experience these, make sure you report these to your provider. And then other stuff, how do we treat heart failure? It depends on what causes the heart failure. Anything can cause heart failure. It could be an infective endocarditis. It could be a myocardial infarction. It could be a cardiac tamponade. It could be a valvular problem. It could be that you have a pacemaker failure. Your SA node quit working. So you're going to have to understand what the causes are and then what to teach your patient. Think about somebody who has infective endocarditis. You would have to make sure you talk to your patient about finishing all of their antibiotics. It's just a big thing you have to talk about. What about somebody who has an SA node that failed and they have to have a pacemaker? What are you going to teach your patient about that? Is it okay to do certain things? You're going to have many questions. Back in the day, we used to talk about not being around microwaves, right? Microwaves aren't like they used to be, but still avoiding magnets and things of that nature when they go to the airport, thinking about going through the scanners. Those are things that could really be eye-opening and scary if they don't know about those. So be certain that you're talking about the teaching and what your patient needs to know. Post-operative, can you shower? Of course you can. So just things of those natures. Be able to identify teaching that needs to occur for patients who have certain conditions. Coronary artery disease is a interesting concept. We're talking about arteriosclerosis, atherosclerosis of the coronary arteries. So you have to think about the heart and understand that the heart is supplied with blood through the coronary arteries. I know it sounds silly to some people that the heart needs to supply itself with blood when it pumps blood through it, but the chambers of the heart do not absorb oxygenated oxygen from the blood that's inside the chambers. The heart muscle itself, the myocardial tissue, gets perfused via the coronary arteries. So when you have somebody who has coronary artery disease, that's typically what ends up leading to a heart attack or a myocardial infarction once you start getting those vessels clogged and you can't perfuse anymore. So understanding that type of patho lets you understand how the patient will present with chest pain. Do they have stable angina versus unstable angina? If they get chest pain when they exercise or move around too much, that would be stable angina. Unstable angina would be sitting on the couch doing nothing and you get chest pain. So being able to teach your patients this is going to be important. Make sure that your patients understand about their cholesterol levels and how to keep those at what level. That's definitely something that ATI and NCLEX is going to look at. How do we fix coronary artery disease? It depends. Typically they're going to go in and do some kind of stent placement. If you have an occluded coronary artery, that vessel has to be opened up, so they do cardiac catheterization, where they'll go in there under fluoroscopy, they'll put a guide wire in and put a balloon basically inside your coronary artery, and they'll inflate a stent, and that stent will kind of revascularize that area, push that clot against the walls, and open it up. Great. You're not going to do that. That's the surgeon's job. Your job is when the patient comes back, what are you going to do? Now at this point, your job is to check for distal pulses and make sure you have good circulation still. Make sure you're assessing the site for bleeding. Make sure your patient's drinking copious amounts of water to get rid of any dye that might be nephrotoxic. Ensure your patient lays in bed for up to 6 hours. Think about that. They put a sheath in the femoral artery and then they take it out. Your risk of bleeding is increased exponentially, especially when you start getting up. So these patients will probably have to lay flat for multiple hours to ensure that clot occurs in the insertion site and it doesn't bust loose and you have bleeding and lack of circulation to your distal extremities. So like I said, just kind of understand what your role as a nurse is. You're not going to fix coronary artery disease. You need to talk about prevention and then what's going to happen in the procedure and after the procedure that the patient needs to know. So that patient teaching component is always going to be huge. Arteriosclerosis, atherosclerosis, they're not the same, but they're one and the same, if you will. Arteriosclerosis, you start getting thick, stiff arteries. All it does is restrict your blood flow. That's basically what we're talking about. It's not a good thing. When you start restricting blood flow through the arteries, it just causes a backup, which increases blood pressure, so it causes hypertension. It also causes a lack of perfusion to the actual organs that are distal to that clot or that hardening. And that's what we're talking about. The difference between arteriosclerosis and atherosclerosis, typically has a plaque that builds up that clogs the artery. Arteriosclerosis is like a hardening of the artery. Atherosclerosis is more of a blockage by plaque. So what are you going to do as a nurse? Nothing. Not your job to fix it. But what you do need to understand is that this disease starts early in life. It's based on the way you eat, your consumption of too many animal products, that high cholesterol, the fats in your diet, smoking, anything that causes inflammation. These things can really, really affect you. So you want to talk to your patients about managing these modifiable risk factors. If you smoke, stop smoking. If you don't exercise, get up and do some exercise, right? Those are things you need to do. Change your diet. Prevention is key. That is where the role of the nurse is going to go in the future. I'm certain of this. So as we kind of think about what our role is, teaching is always going to be something that comes to my mind when we talk about anything cardiac related. Hypertension, you all know about high blood pressure. Everybody in the world, it seems like, has hypertension nowadays, right? Primary hypertension accounts for about 90% of all the cases, and it's associated with multiple factors. Not one factor can be identified as the cause. It's likely, like we said, a combination of things. It's your family history, it's your age, it's how rough of a life you lived. Men are more likely to have risk factors for hypertension than women. Ethnicity plays a role. So there are things you can't change, and that's important for you to know as a nurse, so you can start anticipating when people might be at higher risk for hypertension. But more importantly, once again, is you need to understand certain things like complications of hypertension. They can lead to a heart attack, a stroke, blindness, peripheral vascular disease, all kinds of things that can happen there. Clinical manifestations of hypertension are important for you to understand. And then look when somebody might be having a hypertensive crisis. A hypertensive crisis is when you get super high and you're not going to perfuse like you should. So if you think what hypertension is, it's high blood pressure, meaning that your heart, specifically the left ventricle, has to pump really hard to go against this gradient and try to perfuse your organs. If you're not perfusing your organs because your blood pressure is too high, what kind of signs and symptoms would you expect? You would expect everything you would think of when your blood pressure is too high. Think about the pressure in your head. So headaches, the pressure behind your eyes, that blurred vision. You're not getting enough blood flow to your lungs, so you're not getting enough perfusion there. You can start having dyspnea and that kind of thoughts there. So it's important for you to understand what hypertensive crisis looks like, so you can identify it early and you can treat. NCLEX expects you as a new nurse graduate to be able to identify life-threatening conditions. They're looking at patient safety. So you have to know what you're looking for. That is your big role in hypertension. The education piece is going to be huge. Once again, this is what nurses are getting paid a lot of money for. Make sure you can talk to your patients about decreasing their risk for hypertension. It's not enough to say, oh, change your diet and exercise. That's cute, but if you don't know exactly what you're teaching, then how are you going to help the patient really understand what they need to do? So NCLEX is going to be specific. If you say exercise, talk about it. Our book says like 40 minutes, like 3 or 4 days a week is what they should be doing. Sodium restrictions. We all know you should eat less sodium, but how much? Less than 2,400 milligrams is what the book recommends as well. So these are things you have to think about. You have to think about taking medications. Medication compliance is one of the best things our patients can do. So we have to talk about this with our patients. We have to talk about what their blood pressure goals are. We need to make sure our patient records what their blood pressures are, and they seek help when they have, hypertensive crisis. Imagine somebody's blood pressure is 200 over 150 or 160. That could require immediate medical intervention. So we'd have to think about that. That could be something that could lead to a stroke. We need to think about the things that reduce the risk of injury and promote safety and patient-centered care. So think about it. If I give you an antihypertensive medication, it's going to drop your blood pressure. That automatically makes you more susceptible to falls. So think about that. If we're treating a patient with a diuretic, what kind of diuretic are we giving you? Are we giving you a loop diuretic? Are we giving you some kind of potassium-sparing diuretic like spironolactone? These are things you have to understand. Why? Because if my patient is on a potassium-sparing diuretic, that puts them at risk for hyperkalemia. Go back to previous chapters this quarter when we talked about electrolyte imbalances. It's important for you to understand what your patient needs to be aware of. You know, if you're on a certain medication, you need to watch out for your potassium levels going too high. If you're on a potassium wasting, what do the signs and symptoms of hypokalemia look like? You know, the lethargy and that weakness. Those are things that your patient needs to be aware of in order for us to ensure they are receiving the care they need most, and that we're preventing injuries and possibilities of falls and safety concerns. All right, let's keep moving along. Peripheral artery disease, we usually say peripheral vascular disease, which can include arteries and veins. There's a little bit of a difference, right? We know that arteries carry blood to the extremities, so if you have peripheral artery disease, you're going to have a lack of blood flow to your extremities. They're going to be cold to touch. They're going to have less hair growth. They're going to be more skinny and kind of emaciated because they're not getting the nutrients and oxygen they need in order for them to be healthy. So pain is usually associated with movement. If you're not getting good blood flow to your extremities and you started walking or exercising, you would expect there to be much more pain because now those muscles are not getting the oxygen and the nutrients they need. So we can typically tell when somebody has PAD versus PVD by the ability to replicate that pain with exercise. Pretty important to understand and teach our patients about. So just kind of know what you're talking about. How do you prevent peripheral artery disease? You and I are not going to treat peripheral artery disease. We're going to talk to our patients about signs and symptoms, you know, what to look out for, what to report to their doctor, and then things they can do to lessen the effects of peripheral artery disease and maybe slow the process. So we know people who are high risk are the ones who have cholesterol issues. So you know you have that hyperlipidemia, diabetics, you don't get good blood flow anyway, coronary artery disease, hypertension, kidney failure. These things are really going to lead to that. Smoking, right? If you've had some kind of stroke, all of these are going to put you at greater risk, if you will. So think about what you're going to teach your patients in order for them to get good blood flow. Don't wear restrictive clothing like sweatpants or those jogger type scrubs that cause a lot of pressure and prevents blood flow. Don't cross your legs, things like that. That's just going to hasten it and make it even worse with delivering oxygenated blood nutrients to your distal extremities. Acute peripheral occlusion. What we're talking about here is the same thing we kind of been talking about. Atherosclerosis that starts to get a little more and more worse, and it occludes blood flow. An acute peripheral occlusion can be anywhere, peripherally, right? Blood flow to your arms, to your legs. That's typically what we're talking about. Internal organs can be affected. So, as the arteriosclerosis, the atherosclerosis start to become even worse, these things are something we have to look out for. So, we usually think about these acute peripheral occlusions like as a stroke, and we'll talk about stroke later on and the need to give TPA to dissolve those clots. But we can even give TPA in people who have other blocked arteries. It doesn't have to be just in your brain. It could be other places as well. All right, the next two diseases I'm going to talk about is Buerger's disease and then Raynaud's. Both of these are pretty interesting. Buerger's disease is an inflammatory disease, and it affects your small arteries and veins, right? Mostly it's seen in men, and it can be directly related to smoking. So smoking cessation is going to be a big thing here. I think we have to stress that my job as a nurse is not to fix your issues. Never will be, never has been, and it's not going to change in the future. Unless you become a nurse practitioner, then great, have a good time with that. But for the time being, as a nurse, what is your role? It's teaching the patient what to look out for, being able to identify where there's an issue, talk to them about the need to avoid the cold. That kind of makes it worse too, because we know that cold will cause that vasoconstriction as well. Smoking, is going to cause that vasoconstriction. So these things are going to make it a lot harder for you to get blood flow where it needs to be. Raynaud's, it's similar. A lot of people get confused with these. Raynaud's is when you start getting that lack of blood flow, a lot of times to your extremities. People typically see color changes in their hands from spasms of the arteries in their fingers, which makes it look very, very pale or pallor. They can be very cyanotic looking. So things that can cause issues, once again, is what you need to talk to your patients about. Smoking cessation. We have to really get into that. Protect your body parts from getting too cold. That cold is also going to cause that vasoconstriction. These are things you have to worry about. Caffeine. Caffeine is a bad thing. It too will cause you to have that lack of blood flow. So just know what to teach your patients, what your role as a nurse is, and that is what we're going to try to test you on more than anything else. Peripheral venous disease. Like I was telling you earlier about peripheral vascular disease as a whole, we had the arteries, now we have the veins. Remember, peripheral artery disease, we're having a lack of blood flow to the extremity. With peripheral venous disease, we're having a problem returning blood back to the heart. So if you understand that pathophysiology, if you're not having blood return back, then your extremities are going to be more swollen and red and warm to touch. Think about a deep vein thrombosis. We all have heard of a DVT. Why? Because DVTs can kill our patients. So when we think about peripheral venous disease, clots come to my mind probably the first thing. And I think about that because it gives you a good understanding of what they're going to look like, right? So make sure you know you're not going to treat PVD. That's not your job. But you need to understand how to prevent things. So if we're trying to prevent a DVT, we need to have our patients up and walking. We need to have the SCDs on their legs when they're laying in bed. We need to treat them with IV heparin sometimes to prevent a certain thing, or maybe like a low molecular weight heparin for as far as preventing. Once you have a clot in your veins, then it kind of changes. Once you have a clot, we don't want you moving around. We want you to lay more still. We don't want to put compression devices on because that would just put pressure in the vessels and cause the clot to be dislodged. This is when you're going to go on IV heparin, and then if you're on IV heparin, you as a nurse need to understand what therapeutic heparin ranges are. And that's going to be included in things like monitoring the blood, the APTT, the INR, that kind of stuff. Know your lab values. If you don't understand lab values at this point, you're going to struggle for the rest of your time in this nursing program. Know that an APTT is 60 to 100. Know what an INR is. Understand what therapeutic looks like versus normal ranges. If you don't understand those, it's going to be hard for you to answer questions on these exams, and you're just going to choose the wrong answer because of that. So these are the things that, go back and study in your book. What is the nurse's role? What can I teach my patient? Venous insufficiency, this we've been talking about. You're going to see that venous stasis in the legs. You'll see those venous stasis ulcers. You'll see the big swollen legs where the fluid starts to seep out of the leg. They typically need to wear some kind of compression stockings to get the blood flow to come back up. So patients typically have more susceptibility to ulcers in their legs, to traumatic events if they get scratched, they have delayed healing, things like that. Varicose veins kind of falls into this same area that we're talking about here. Varicose veins are protruding veins, usually in the more superficial areas of the lower extremities. If you stand for long periods of time, you're very obese, pregnant, if you have any kind of systemic heart disease that precludes that good venous return, your chances of having varicose veins will go up drastically. So are you going to treat varicose veins? No, we don't do that, not our job. Nursing interventions focus on assessing circulation and understanding what's going on. So, do mild exercising like you should. Wear compression stockings to help push that extra cellular fluid back into the intravascular spaces and get it back up to the heart where it belongs. If you're overweight, lose weight, right? Things like that. If you smoke, stop smoking.
all of the same things apply. I know what I'm talking about sounds very simple, and you're like, come on, man, this can't be what we need to know. I'm telling you, it's what you need to know, because your role as a nurse has nothing to do with fixing the problem. That's not your job, that's the doctor's job, right? Our job is the things that include teaching and safety and making sure our patients understand what to do when they leave and go home. Amputations is the last part that we're going to talk about based on our syllabus. And amputations are different. They are included in the cardiovascular section because a lot of times people don't have good blood flow to their extremities. It could be caused by peripheral artery disease, hypertension. Hypertension we know leads to kidney issues as well, diabetes. All these start being related, and we understand that this lack of blood flow becomes very problematic. So we include this in here for that reason. You need to understand that if somebody has an amputation, what is your job as a nurse? Once again, it's to teach. It's to help prevent these contractures and stuff. You know, it's having the patient lie prone when they have a below the knee amputation, so the limb can be pressed down into the bed as you prepare for a prosthesis, right? Don't put pillows pillows between the patient's legs or under the butt. Make sure you talk about stump care and what you need to do there. Understand this phantom leg pain. That happens all the time. Just because it's not there doesn't mean your brain doesn't perceive it. So understand what kind of medications they're going to have to take for that. This is all part of the teaching, and this is your role as a nurse. So I'll recap and say this. Yes, everything in the book's important. Everything in the chapter's super important. Understanding the pathophysiology and etiology and anatomy and physiology will help you better understand, why the signs and symptoms exist. When you understand arteries deliver blood to the extremities and you have peripheral artery disease, now you understand why your legs are cool to touch and don't have hair growing, things like that. You understand with the vascular issues, with the venous return, you're having a problem bringing it back, so they're going to be swelling. So it's important to know that. But more importantly for your exams and to get out of nursing school is understanding what your job as a nurse is. Once you can figure that out, things are going to be very, very more advantageous on your test grades and your results after exam night.